Leah says about sciatica. I have a very big question in mind. I've tried two different ways when people come to see me with sciatica. The first way is I move them in a gentle way and not put weight on the painful leg. And the second one is move it and load it. All right, so firstly, just as an aside, sciatica is essentially leg pain that is associated with back pain. So it's basically leg pain that is caused by some kind of irritation to the nerves that come out of the low back and go down the leg. And the name of the major nerve that goes down the leg is the sciatic nerve. And so if that nerve is kind of irritated somewhere in the low back, you can have symptoms of pain in the leg, even though the cause of the problem is most likely in the low back. All right, so Leah's question about sciatica is she has two different approaches. One is to move it gently and not load it. The other one is to move it and load it. Sometimes people get better with one and sometimes the opposite. It's really tricky. I don't know how to help them. I actually tried two opposite ways and sometimes it works and sometimes not. Different people who feel better when they isolate versus move. So basically, it's not the same person that sometimes moving helps and sometimes not moving helps. But sometimes some people feel better when they move the painful bit and other people feel better when they don't move the painful bit. And so the question is basically, how do you know which to do? Should you move or should you not move? All right, so I did some research on this and here's what I came up with. So there's good news and bad news. Well, the bad news is that, actually there's good news and bad news and good news. So we'll start with the good news. The good news is that the prognosis, the natural history of sciatica, what's likely to happen if it's left untreated. So if you have raging leg pain that goes into your bum or your back of your thigh or down the side of your calf and into your foot, any combination of those body parts, if you have that with or without back pain, the prognosis, if left alone, it's very likely to go away within a year. And that is for the majority of people. And actually, people with worse pain at baseline are more likely to recover if the sciatica is caused by a disc bulge or a disc prolapse or something like that. So people with a worse disc prolapse are more likely to recover. So that's the good news. So really, if it's fairly recent onset sciatica, the good news is it's probably going to go away all by itself within about a year. The bad news is, through quite a number of systematic reviews, exercise has been shown to be marginally effective for sciatica. It's not been shown to have great benefit. There are lots of benefits to exercise that are not specific to sciatica. So exercise certainly can help people with their mood and their optimism and their general health and quality of life and their functional capacity, their ability to get around and do stuff. But it hasn't been shown to be terribly effective for pain related to sciatica. So that's the bad news. Then there's the good news. The good news is I found a really fantastic little guideline summary from NICE, which is the National Institute of... What's NICE stand for? I looked it up before and then I forgot what it stood for. National Institute for Health and Care Excellence in the UK. So it's the United Kingdom's nationalised health service. The NICE guidelines for managing low back pain and sciatica. And they have not only a set of scholarly printed guidelines, I've got this marvellous little infographic. So I've shared that with you here. And this is the current NICE guidelines from 2017, managing low back pain and sciatica. So here's the decision tree. So firstly, and Leah, I know that you already know this, but this is just what the guidelines say. Firstly, exclude specific causes of low back pain, for example, cancer, infection, trauma, inflammatory disease, or cauda equina. So that's in what we learn in the Cert 4 and the diploma as essentially screening for red flags. So we first screen for red flags, which I'm sure you've done, and that's only if someone has new onset sciatica. So if someone comes to you and they've had sciatica for some period of time, previously, then you don't need, and they've already seen another healthcare provider about it, you don't need to screen them for red flags. But if it's new onset, you do need to screen them. Do not image. Only consider imaging in specialist care and if it's likely to alter management, which in this case it's not. Assess the likely recovery outcomes. Now, what they say here is that the indicators of poor outcomes are fear and pain avoidance, low mood, job dissatisfaction, and ongoing litigation. And I found a couple of systematic reviews from the last couple of years that also found that poor expectation of outcome is a very strong predictor of outcome. And all of those are, in fact, psychosocial factors. So if they have more of those indicators of poor outcome, they should probably receive more intensive interventions, which is combined physical and psychological interventions. So they should probably be referred to somebody who can coordinate a multidisciplinary approach if they have a lot of those indicators of poor outcome. If they don't have a lot of those indicators of poor outcome, then they should go into group exercise. And what's recommended is some combination of yoga, Pilates, Tai Chi, cycling, group fitness, just general movement, basically, stretching and strengthening. There are no specific recommendations for moving them forwards or backwards or isolating or anything like that. If that doesn't help, which sometimes it doesn't, or even fairly frequently it doesn't, the management options are neuropathic pain medication. So these are things like gabapentin and epidural steroid injections. So just injections into the back of steroids or local anesthetic, and spinal decompression surgery. So all of those things have reasonably good support in the literature that they do in fact improve outcomes more than exercise, even when it's combined with manual therapy. You can add in manual therapy and psychological therapy, but they should only be adjuncts to exercise. So you shouldn't have the manual therapy or psychological therapy as the main treatment modality, but they can improve outcomes when added to exercise. And paracetamol shouldn't be used, so Panadol or acetaminophen as it's called in the US. NSAIDs, non-steroidal anti-inflammatories, so things like ibuprofen, which in Australia has a brand name of Nurofen, or things like Voltaren, they're non-steroidal anti-inflammatories, and also weak opioids. So, of course, as Pilates instructors, we're not giving people injections or prescribing medication, but this is just so you know. These are the guidelines, and do not offer acupuncture because it doesn't help. So those are the NICE guidelines, and I will link to those in the description of this video. Finally, I just want to talk through a plausible sort of anatomical explanation of why some people get better, get temporary relief from sciatica with gentle movement and some people don't. Now, this is not based on any study or science. It's just me kind of reasoning from first principles about potential mechanisms for your experience. There are many other potential mechanisms, like, for example, maybe it's not related to what you did. Maybe it's related to that person's expectations about what you did. You know, if they expect moving to make it better, moving is more likely to make it better. If they expect working with you to make it better, working with you is more likely to make it better. If you had a more positive interaction, if you had a better therapeutic alliance with that person, you know, and so whether you got them to move the body part or keep it still might have just been kind of incidental to whatever benefit they got from the interaction. So there are many, many possible reasons called contextual effects for why someone might feel better after you gave them an exercise that have nothing to do with which exercise you gave them or any sort of physiological direct effect of that exercise. However, there are also a couple of explanations that do involve mechanisms of the exercise. So let's talk about one of those. All right, so if we think about your vertebral bodies, discs, here's your spinal canal with your spinal nerves in it, and this spinal nerve exits through this neural foramen here and then splits off into different nerve tracts, and we'll call that the sciatic nerve. And then if we draw in the rest of your vertebrae, this would be the spinous processes, etc. And that might be your L3 your vertebra, your L4 vertebra, and your L5 vertebra. And this would then be your sacrum down here, S1. All right, so that is the kind of a side view. And so this is your spinal cord, and that is your sciatic nerve, which is just a branch that comes off the spinal cord and then goes down your leg. And so there are two possible mechanisms. Now, like I said, there are many other mechanisms. These are just two that kind of came to my mind when I was thinking about this. So the first possible mechanism is a disc bulge. Let's create a disc bulge here. All right, so if we create a disc bulge that bulges out here, okay, and kind of presses on the sciatic nerve where it exits out from the spinal canal, and it presses on the sciatic nerve. And so basically in that situation, anytime you move, you know, if you bend your back forwards, okay, you bend forwards, or if you bend backwards, you are going to cause that nerve to essentially get dragged across that disc bulge like a violin bow across a violin string, and you're going to kind of scrape that nerve along the disc bulge, and that's going to cause some kind of irritation and potentially symptoms in the leg and potentially symptoms in the back as well. So that is, you know, if the cause was a disc bulge, there are many other potential things that could cause it, but if the cause was a disc bulge, and if the disc bulge was pressing on the nerve in a particular spot, such that when you bend that spot, the nerve is kind of scraped across the disc bulge, well, that could explain why moving hurts and keeping still doesn't hurt. So that's one possible explanation. And now if we get rid of our disc bulge and think about a different possible cause. So let's think about, in fact, let's get rid of this altogether and create as like a slightly different view. So this is the inside of the spinal canal, and here is the neural foramen. Now, I know this isn't anatomically accurate, but it's about as good as my powers of drawing allow me to do. So on this side is the vertebral body, and on this side is the next vertebral body, and here's the spinous process. And if we look from the side, this would just be a solid mass, like right across here would all be just solid. But of course, I've cut that away for you so we can see into the spinal canal. So, all right, let's get rid of this bit here because that's kind of silly, but this looks pretty good. I like that. So here's our spinal canal, and here's our nerve tract. Okay. Our nerve tract is composed of a tract is just a whole bunch of nerves that are kind of bundled together, and then a smaller nerve tract comes out here, and this one continues on down. Now, in fact, the nerves don't come out exactly like that. What actually happens is these nerves here end about there, and then they join to new nerves. These nerves here, these are the tails of nerves that are where the nerve cell bodies are in your brain. And these are the long tails that reach down. And they synapse here with a new nerve. So there's a new nerve body here, and a new nerve body here, and a new nerve body here of all these different nerves. And then these tails of these nerves go out down your leg to different places. So these are basically nerve bodies. And so this, where the nerve comes out from your back is called a nerve root. And it's a bit bigger. It's a bit bigger than the general body of the nerve. It's kind of a bulge, just like I've drawn it here. I think that's the best part of my whole drawing. So there's a bit of a bulge. There's the nerve root, which is simply composed of all of the cell bodies of those neurons, those nerve cells, that form that nerve tract. You know, all of the cell bodies are in that nerve root. And then the tail, each one of these has a little tail that is an individual nerve fiber. An individual nerve fiber. And the tails are much narrower than the heads, than the cell bodies. So the nerve tract, is much thinner than the nerve root. All right. And of course, this is your spinal cord. Now, before we said imagine a disc bulge. Okay. So what I'm going to posit now is an alternative possibility. So imagine there is no disc bulge, but let me just wave a little magic wand and somehow create some kind of irritation inside your spinal canal. You know, like some kind of inflammation. You know, something rubs, or there's an infection, or there's some minor irritation in there. You know, sometimes you get an irritated finger, sometimes you get an irritated spinal canal. It's just like one of those things. Who knows why it happens? So allow me to create some little bit of inflammation in there. Well, what happens when something gets inflamed is you have more fluid is attracted to that area, is one of the things that happens. And in your finger, when you get an inflamed finger, that's what happens is then your finger swells, you know, gets bigger. However, this is a hollow bone tube. So this is a bone tube. Your spinal nerves live within a bone tube inside the back of your vertebrae, and that is called your spinal canal. And that space is your spinal canal. It's a bone tube, so it's not stretchable. And if you squish more fluid in there, okay, if we put more fluid in there and we fill that up with more like fluid, like cerebrospinal fluid plus a bit of inflammation fluid, the pressure increases. Okay, it's like if we forced more lemonade into the lemonade bottle before we jammed the lid shut. It's got more pressure in there. Now that pressure can cause the nerve to become irritated. It can cause the nerve to become irritated. Just the pressure from the increased fluid that is just a result of just a normal low-grade inflammation. So in this case, that person now might have pain that they experience as coming from down their leg somewhere, whereas in reality, the nerve is being irritated inside their spinal cord or right at the exit to the spinal cord. So in that case, if you gently move this area, like with, say, a cat stretch or some gentle pelvic curls, some kind of gentle movement, what can happen is that movement will clear the inflammation. It will pump some of that fluid out. Okay, it will reduce the pressure in the spinal canal and thus alleviate that irritation on the nerve, which could well alleviate the symptoms. So there are two possible mechanisms for how sciatica may have a relationship with what's going on in the low back, and a plausible reason, I think, why in some cases keeping it still could help, and in other cases moving it could help. But I really do want to emphasize that probably, based on the research that I looked at and the NICE guidelines, that there probably is very limited benefit from any kind of exercise in relation to sciatica. And probably most of the benefit that your clients are getting from their sciatica, pain relief from their sciatica, from working with you, is to do with contextual effects, so non-specific effects. The feeling more better self-efficacy from doing something for themselves, feeling a strong therapeutic alliance with you, feeling that you care for them, that they trust you, and that you're working, for their best interests. Expectation effects, expecting that they will benefit from doing exercise, therefore they do. Social support of hanging out with other people who are also exercising, maybe also experiencing, physical pain and getting better and working through the trials and tribulations that entails, and everybody's in it together, and that can help. So there are a whole host of other non-specific effects that we could list. It could also just be maybe they didn't get better as a result of anything you did. Maybe they were just on the way up anyway. Like if you look at any. If you look at, most people with chronic pain, whether it's in the leg or the back or wherever, there are bad days and there are good days, and there are bad days and there are good days. And for most people, it's not exactly regular like that, but it's, goes up and it goes down. And people might have their worst day, and their best day, and their worst day, they might have like a 7 out of 10 pain, and their best day, they might have a 3 out of 10 pain, and most days it's somewhere in between that. Okay. Well, if they come to you and they got a 7 out of 10 pain, it's almost certain that next time you see them, they're going to be better. Right? And that's called regression to the mean. Regression to the mean. And what that says, all it says is when things are at their worst, they are very likely to get better. Okay. And then they might get better the next day, and then they go, oh, it was that magic stretch that Leah did with me. But in reality, it was just, they were just going to get better anyway. So there's probably some combination of all of those things that I've just mentioned, plus a half a dozen or 10 other things. So Leah, I hope that helps. I guess, practical takeaways from that. don't worry too much, because probably very little you do in the way of exercise is going to have much of a specific effect one way or the other. It's probably more about how you give the exercise, as in your, the conversations that you have, your tone of voice, your eye contact, expectation, care, all of that stuff. And secondly, that if somebody responds well to gentle movement, great, do more gentle movement. And if they respond well to not moving it, but moving their other body parts, great, do that. And I hope that helps.